Endocrine Fellows Metabolic Bone Forum. And I'm going to be speaking to you guys twice. The first time today I'm talking about hypoparathyroidism, and I think on Monday I'll be talking about diabetes and bone. So feel free, of course, to interrupt me with any questions. My disclosures. Okay, so I have a few cases that are designed to highlight different points. So for the first case, a 36-year-old woman comes in for a 1-month follow-up after a total thyroidectomy for papillary cancer. She's complaining of intermittent numbness and tingling of her fingertips and around her mouth. She's taking her daily thyroxine. On exam, she has a negative Schwastek sign, but a positive Trousseau. Her labs show that her serum calcium is low, 7.5. Her albumin is normal, 4.0. Her phos is elevated, 4.9. Her MAG is normal, 1.8. Her creatinine is normal. Her PTH is low, 10. And her TSH is low, 0.2. You conclude that A, she has permanent post-surgical hypoparathyroidism and should begin treatment for this. B, she requires additional thyroid hormone therapy. C, calcium supplements should be started and further monitoring in 6 months should be done. D, vitamin D2, 50,000 units a day should be initiated. E, vitamin D deficiency should be excluded to explain the symptoms. Here, I'll go back to the labs. So again, she has the low calcium, the high phos, normal MAG, low PTH, and low TSH. Okay. So do we think this is permanent post-surgical hypopara? Right? Why not? Exactly. She's coming at 1 month. Do we think she requires more thyroid hormone therapy? Her TSH is already suppressed, so we probably wouldn't want to give her more thyroid hormone therapy. Should we start calcium supplements and then repeat her labs in about 6 months? Probably. I mean, you'd probably want to do it in sooner than 6 months, but this is what's meant to be the right answer. Why would you not start vitamin D on her? Does she look like she has D deficiency? What would be different if we thought she had D deficiency? Right, so probably if she was D deficient, her PTH would be high and her phos would be low, but instead we see her phos is high and her PTH is low. So this is someone who has new onset hypoparathyroidism, and we don't know if it's permanent or just transient. So from this case, I'm going to go through these points to talk about a little bit about the epidemiology of hypopara, how we diagnose it, why it could happen, what are the symptoms and what are the signs. So it's thought to be present in about 60,000 people in this country. That's data from like insurance companies. It's thought to be an orphan disease. Does anybody know how something's considered an orphan disease, how rare it has to be in America? If it's present in less than 200,000 people, it's considered an orphan disease. And that's important because then the FDA will consider it differently, and it's much easier to get a drug approved for an orphan disease. Most commonly, it's due to damage from neck surgery. So a patient who's having surgery for thyroid cancer is the most typical scenario, but it could be surgery for primary hyperpara. And the risk is about 2%. So it happens in about 2% of patients who undergo anterior neck surgery. And kind of what you would imagine, it makes sense that it's more common in a place where the surgeon is less experienced. So with a more experienced surgeon, it'll be less likely to happen. But the main thing is that it's a very rare disease. Do any of you have hypopara patients in your clinic population? Do you have a question? Just one? Yeah. Right. So I think that's kind of reflective of the demographics of it. So in order to make the diagnosis, does anyone know what are the criteria you would have to meet to say that someone has hypopara? What would you think they would need to have?
So calcium was normal or inappropriately low PTH.
Exactly right. Exactly right. So the guidelines that have been published I don't know why you can't really see the bottom, but whatever, they were published in the JCNM in 2016, say that you need to have hypocalcemia at least 2 times, at least 2 weeks apart. And just like you said, it needs to be accompanied at the same time with a PTH that's either totally undetectable or inappropriately low. And as a rough rule of thumb, we consider low a PTH less than 20. It's helpful if you see an elevated phosphate, but you wouldn't need to see that in order to make the diagnosis. And like we were kind of implying with the first question, in order to say that this is chronic, it needs to be present for at least 6 months after surgery. Until 6 months, I guess there's the hope that it might be transient and resolve, but after 6 months, that becomes very unlikely. So we're probably familiar that you need to use the corrected calcium. So to make the diagnosis, it needs to be a corrected serum calcium. So we know that about 40% of calcium circulates bound to albumin, about 15% bound to citrate and sulfate and other ions, and about 40% is the ionized, biologically available, free form, and that's, of course, the one we care about. So you always want to use this equation in order to be able to get your corrected calcium. It's also important to keep in mind that the acid-base status will impact how much the ionized calcium is. So if a patient is more acidotic, then more of their calcium goes into the ionized free state. So you just need to keep that in mind. Like, let's say if you have a patient in renal failure who's hypocalcemic, if you're correcting her acidosis, you might be putting her at risk for some of her ionized calcium to drop, because if you're keeping someone in an acidotic state, they have more ionized calcium, and if you reverse that, they'll have less of that. So 3/4 of hypoparic cases are due to post-surgical injury or inadvertent removal of the parathyroid gland, and these can happen for goiter or thyroid cancer or other causes, but that's the typical thing, that it's post-surgical. In terms of the non-surgical etiologies, you can have a calcium sensing receptor mutation. So that's also known as autosomal dominant hypocalcemia. So that's when the calcium receptor is mutated and thinks that there's too much calcium around all the time. So it thinks that your calcium is high, so you're inappropriately pouring calcium out into the urine. But those patients generally feel fine and do well, and the main concern with them is that they should actually not get overtreated with calcium and vitamin D, because then they're at risk for nephrocalcinosis. And of course, the flip side of the autosomal dominant hypocalcemia is when you have familial hypocalciuric hypercalcemia. So that's when you have the opposite problem, that the calcium sensing receptor always thinks that there's too little calcium around. So those are two different mutations where the set point of the receptor can be shifted in either direction. DeGeorge syndrome is when someone's born without development of the parathyroid glands. And this is autosomal polyendocrine syndrome. So this can happen just with isolated, it's not autosomal, autoimmune polyendocrine syndrome. It could just be with hypoparathyroidism or with other endocrine deficiencies. So sometimes these patients can be hypoadrenal and can have vitiligo or candidiasis, although sometimes they can just have hypopara alone. You can also have acquired causes, so you can have an antibody against the calcium sensing receptor, so that for all intents and purposes would look like autosomal dominant hypocalcemia, where the receptor is constitutively turned on. Heavy metals, so if you have Wilson's disease or hemochromatosis, that can cause hypopara, but I think that's very rare. And infiltrative, let's say that could be from cancer or from sarcoid, but again, I think that's very rare. And then importantly, which somebody mentioned, hypomagnesemia can cause a functional and reversible hypoparathyroidism. And that's very important because if a patient's magnesium is too low, they'll have two problems. They won't make enough PTH, but probably even more important than that, they're resistant to PTH. And that's because you need magnesium in order to bind to the adenylate cyclase that happens after the PTH binds to the PTH receptor. So it's important because if a patient has a low magnesium, you could replete their calcium forever and it's not going to come up. So you need to always remember to correct the low magnesium first. The opposite can also happen if someone has hypermagnesemia. So this might be happen in a woman with preterm labor, where sometimes they give magnesium as a tocolytic therapy. So that can also cause resistance to the actions of PTH, but that's a more unusual situation. So the main point here is that you always want to rule out low magnesium. So you would probably especially think about that in someone who's malnourished or pancreatitis or someone on cisplatin therapy. They can waste magnesium in the urine. So this is a functional reversible cause of hypoparathyroidism. So the symptoms of hypopara are those of hypocalcemia, and they're mainly symptoms of neuromuscular irritability. So the patients will say that they have numbness and tingling in their fingers and toes and around their lips. Their muscles can feel twitchy. They could feel like they have spasms. It's very unusual to have a cardiac arrhythmia, but it is something to consider. And then if it becomes more severe, they can develop tetany and have seizures. And cataracts are also thought to happen as part of a buildup of soft tissue calcifications. With hyperphosphatemia, the main thing that we worry about is ectopic calcifications. So this is just to make the point that tetany in association with hypocalcemia is a life-threatening complication and can be an acute medical emergency. So a svastik, everyone probably is familiar with doing that, but you tap on the facial nerve, and then if you get a twitch on the same side, that's considered a positive svastik. So does anyone know, is it a sensitive and specific sign? Can we totally hang our hat on it? Right, not really. So about a third of people who are hypocalcemic won't have a positive svastik, so it's not that sensitive, and about 10% of normal eukalcemic people will have a positive svastik, so it's not that specific either. But in contrast, Trousseau's is a lot more sensitive and specific and is present in over 90% of people who are hypocalcemic and only like 1% of people who are eukalcemic. So you guys probably know that you need to inflate the blood pressure cuff, and that will elicit ischemia in the limb, so the patient's hands will go into tetany if they're hypocalcemic. So that would be your more reliable test. We do worry about prolongation of the QT interval. It's generally considered that if the QT is longer, the corrected QT is longer than 0.45, that puts the patient at risk for arrhythmias. So for example, if you're considering whether you need to treat someone in the hospital with IV calcium, if they have a prolonged corrected QT interval, that would certainly be an indication for acute treatment of hypocalcemia. So to summarize the points that I wanted to make from the first case, first, that it's a very rare disease. Second, that to make the diagnosis, you want to have a low albumin-corrected serum calcium concomitant with a low PTH at least 2 times, and it should be at least 2 weeks apart. It's mostly because of surgical injury to the parathyroid glands, and the predominant symptom is that of neuromuscular irritability, so kind of this twitching and numbness. Any questions before I go on to case 2? Okay. Yeah, and the signs that we can do the svastik and Trousseau, with Trousseau being a little bit more reliable. Okay, next case. A 50-year-old woman comes with a history of low serum calcium values. Some of these date to 20 years ago. She thinks her mother perhaps had low serum calcium too. She has no complaints. She had 1 kidney stone 5 years ago. She's taking calcium supplements to prevent perimenopausal bone loss, 500 milligrams of elemental calcium a day with 200 units of D3 a day. Her labs show that her serum calcium is low at 7.1. Her albumin is normal. Her serum phosphate is at the upper end of the normal range of 4.5. Her PTH is low at 15, and her 24-hour urinary calcium level is elevated at 490 milligrams over 24 hours. And her renal ultrasound shows that she has nephrocalcinosis and 2 non-obstructing stones. So the differential diagnosis includes A, vitamin D deficiency, B, resistance to PTH action, C, autoimmune polyglandular failure type 2, D, activating mutation in the calcium sensing receptor, E, resistance to 125 dihydroxyvitamin D action. So let me just go back to, so she's had low serum calcium for a long time. She doesn't have symptoms for it. There might be a family history of it. She has had nephrolithiasis. Her calcium and her PTH are low, and her urinary calcium is high, and she's evidence of kidney stones. So does anybody think she has vitamin D deficiency? No, I agree. We wouldn't think so because, again, if she had D deficiency, her phosphate would be low and her PTH would be high. Resistance to PTH action, do we think she has that? Right, so what would that look like? Right, exactly. You'd have a high PTH. Does she have autoimmune polyglandular failure type 2? It's possible. I mean, she doesn't have any of the stigmata of other endocrine deficiencies or any of the skin manifestations. So that is a possibility. An activating mutation in the calcium sensing receptor. So that's meant to be the right answer because she is really asymptomatic with it. There seems to be this family history, and her urinary calcium is so high. And resistance to 125 dihydroxyvitamin D action, so her labs aren't consistent with that. We would also see a high PTH with that. Okay, so from this case, I'm just going to talk a little bit more about, to use this example, to talk more about the physiologic effects of PTH on the kidney and the bone and the GI tract in terms of calcium and phosphate, the ectopic calcifications that can develop when you don't have enough PTH, and the GI effects. So PTH will regulate calcium metabolism through its interaction with 3 main organs. One is the kidney. So PTH will stimulate reabsorption of calcium in the distal convoluted tubule at the kidney. So if you don't have enough PTH, you're not able to reabsorb the calcium adequately that's filtered through the kidney. PTH will also stimulate absorption of calcium in the intestine indirectly by stimulating the 1-alpha hydroxylase that'll convert 25 vitamin D to 125 dihydroxyvitamin D in the kidney. And PTH will also mobilize calcium from the bone by stimulating bone remodeling. So we'll talk a little bit about each of these things in more detail. So first, in terms of the kidney, so we filter about 8 grams of calcium a day. And a lot of that, most of that is reabsorbed, and that's just passively being reabsorbed in the proximal tubule. And that's just because of the concentration gradient and the charge gradient. And there's also calcium sensing receptors throughout the entire nephron. But here at the distal tubules where PTH acts, and that's where active reabsorption of calcium happens. So if PTH is lacking, you're missing that active reabsorption and you'll lose a lot more calcium into the urine. So if you have a hypopara patient and they're not actually taking any calcium or calcitriol, their urinary calcium is actually not that high because they're just not really filtering that much through the nephron. But once you start to give them calcium and calcitriol, that's when their urinary calcium is really going to get high because they're not able to reabsorb the calcium from the extra filtered load that's passing through. So the other important point is that at the kidney, 1-alpha hydroxylase is stimulated by PTH to make 125 dihydroxyvitamin D. And the other important point is that having a high sodium is going to cause more hypercalciuria. So it's always important to tell these patients that they should be on a low sodium diet because that will prevent or minimize the urinary calcium loss. In terms of phosphate metabolism at the kidney, so like calcium, most of the phosphate that's filtered is going to be reabsorbed by co-transporters with phosphate called sodium phosphate co-transporters. So if you have PTH, it will decrease the sodium phosphate co-transporters, so you have less phosphate reabsorption. So that's why if you have hyperpara, you're going to be urinating out a lot more phosphate and have a low serum phosphate. But without PTH, as in hypopara, there are actually more transporters around, so a lot more phosphate is getting reabsorbed in the kidney, and that will lead to the high phosphate serum levels. So normally, if you have a high phosphate, bone can buffer some of that, but the problem with hypopara is that because, as I'll tell you, bone remodeling is so low, the high phosphate isn't able to be really buffered. And that can actually make some of the vascular smooth muscle cells become more like osteoblasts and actually start to calcify as though they're osteoblasts. And we know that vascular calcification and nephrocalcinosis and basal ganglia calcifications are the main things that we worry about, especially calcification of the kidney. So probably the biggest morbidity with these patients is that they can go on to develop renal stones and renal calcification. We think that happens in about a quarter of these patients. And some of them can get basal ganglia calcifications. Nobody really knows how frequent it is because it's never really been systematically looked at. But some of these patients look like they really have advanced Parkinson's disease because of the basal ganglia calcifications. So in terms of the PTH effects on the GI tract, we generally ingest about a gram of calcium a day, but only about 100 milligrams is absorbed. And PTH will enhance the absorption of calcium in the intestine by making more 125 dihydroxy vitamin D. Okay, so to summarize the points that I wanted to make from this case vis-a-vis the pathophysiology of hypoparathyroidism, in terms of the effects on the kidney, so PTH will actively reabsorb calcium at the distal convoluted tubule. And this is also where thiazide diuretics will act. They'll also enhance calcium reabsorption at the distal convoluted tubule. PTH will decrease the transporters in the distal tubule so that there's less phosphate reabsorption and more phosphate excretion. So when you're lacking a PTH, as you are in hypopara, you're going to have more phosphate reabsorption and less phosphate excretion. And these patients are at high risk for developing ectopic calcification in the kidney and in the brain. And in terms of the GI tract, the 1-alpha hydroxylase that is at the kidney will enhance calcium and phosphate absorption in the intestine. Okay. So I'm going to move on now to case 3. So a 55-year-old professor comes in with chronic hypoparathyroidism since goiter surgery as a teenager. She has hypothyroidism and had DCIS 4 years ago with lumpectomy only. She is taking calcium carbonate 1,500 milligrams twice a day, calcitriol 0.5 micrograms twice a day, levothyroxine 125 micrograms a day. She broke her wrist 5 years ago after falling. She tells you, this is a direct quote from a patient of mine, "I am considering declaring disability because I can no longer function adequately in my role as a professor. The brain fog is so bad that I cannot finish sentences and I get lost when driving in my neighborhood. The fatigue limits me to 1 activity per day. I can go to the store or I can cook or I can clean the kitchen, but I cannot do more than 1 activity." I don't know if any of your hypopara patients complain of this type of brain fog, but in my experience, it's a very, very frequent, debilitating complaint for these patients, and they're actually a lot more worried about the brain fog than they are about their kidney or other long-term physical effects. Her labs show that her serum calcium is 9.8, so that's kind of normal for a euparathyroid person. Her serum phosphate is 6.4, so that's elevated. Her calcium phosphate product is 63. Her creatinine is normal. Her PTH is 5, so it's low. And her bone density T-scores show plus 2.1 at the lumbar spine, plus 1.2 at the femoral neck, plus 1.8 at the total hip, and minus 0.9 at the distal 1/3 radius. The next step is A, change her calcium supplement to Posture D. So she was on calcium carbonate. It's a calcium phosphate product, calcium phosphate supplement. Obtain a neurological evaluation. C, start a phosphate binder. D, have her dose of calcitriol to 0.25 micrograms BID. So she was on 0.5 micrograms BID. Begin PTH 1 to 34, 20 micrograms sub-Q BID. So I'll just go back to the case for a minute. So she's on calcium carbonate 1500 twice a day, calcitriol 0.5 twice a day. She broke her wrist. She has a lot of brain fog. Her calcium is normal for euparathroid patients. Her phosphate is high. Her calcium phosphate product is 63, which we would consider high, with an acceptable cutoff generally considered to be 55. Her PTH is low, and her T-scores and her bone density are generally elevated. So who would think to switch her from calcium carbonate to Posture D? We wouldn't, because as we said, it's a calcium supplement that contains phosphate. So with these patients, you're worried that their phosphate's too high. So you certainly wouldn't do that. Obtain a neurological evaluation. I mean, you might consider that. I actually have a hypopara patient who, was being followed by neurology, and they had no idea why she had so many cognitive symptoms and didn't really think about the hypopara. So I think, we'd keep it on the back burner, but probably not start with the neurologic evaluation. Would we start a phosphate binder? She did have a high phosphate and a high calcium phosphate product. So you could consider that. Of course, that's something that's done with renal patients, but it's not usually the first line of therapy in hypopara patients. We think of other ways to get their phosphate down. Would we consider having her dose of calcitriol from 0.5 twice a day to 0.25 twice a day? Mm-hmm. Yeah, so what's your thinking with that?
Her calcium is a goal.
Exactly.
For euparathroid, so for her, that you're aiming for it to be less.
Exactly. So usually we want these patients to have a calcium that's in the lower ends or even below the normal range. So really never above 8.5, usually like around the 8s is probably good, although each patient is different. And the calcitriol is also most likely elevating her phosphate and her calcium phosphate product. And would we begin PTH 1 to 34, 20 micrograms BID? What?
In Italy.
In Italy, we would. Exactly. Guy is exactly right. So it's not approved in this country for hypoparathyroidism. We'll talk in a minute about PTH 1 to 84. But in other countries, you might consider using it for hypoparathyroidism. Although I don't know if you would use it BID. It is BID? Okay. Okay, so the right answer would be D. You would want to lower her calcitriol to get her phosphate and her calcium phosphate product down. So the points I want to make in this case is the management of chronic hypoparathyroidism. So first to talk about the quality of life effects, the skeletal effects, what your therapeutic goal is, and how you would manage these people long term. So this is work that Natalie Cusano did here, and Gaia has taken up the continuation of it, where they've used the SF36 questionnaire, which is a very well-validated quality of life questionnaire. And this is in hypopara patients, showing that both in emotional and physical domains that the hypopara patients had lower scores. And what's interesting is that all these hypopara patients had normal calcium levels because they were all on calcium and calcitriol supplementation. So normal or low normal, but even when they were appropriately treated with calcium, they still had this brain fog. So it's not like you could say it's a hypocalcemic effect, but it seems to be something specific about being deficient in PTH. So despite being eucalcemic, they scored lower. In terms of the skeletal effects of PTH, so you need PTH both to stimulate bone resorption and to stimulate bone formation. So we know how these happen, that PTH will cause the osteoblasts to make rank ligands, and then rank ligands will come and bind to its cognate receptor rank on the osteoclast and stimulate osteoclast proliferation and differentiation, and thus lead to more bone resorption. And PTH will also stimulate bone formation because it blocks sclerostin, and we know that sclerostin is this bad factor that blocks anabolic activity. It blocks the Wnt beta-catenin anabolic pathway. So PTH is obviously pivotal for stimulating bone remodeling, both by stimulating bone resorption and stimulating bone formation. So it follows that when you don't have enough PTH around, then the skeleton goes into a very low bone remodeling state. So in association with that, these patients tend to have very high bone mineral densities. And you could see when we looked at this more closely on bone biopsies, you could see both that there's more trabecular bone. So, you know, this kind of honeycomb Swiss cheese compartment of the bone, that these trabeculae, if you measure them, were thicker, if you quantify it, and there are more of them as compared to normal. And the cortical envelope here in a normal person, you could see is thicker here. And if you measure it out, the width of their cortical bone is greater. So they basically have more bone, both in the trabecular compartment and in the cortical compartment. And that's really because bone is just accumulating, so it's not being replaced and remodeled as it would in a normal person, and that's because there is a deficiency of PTH. So that would make you ask the question, well, are they more likely to fracture or not? You know, on the one hand, you might say, well, of course, we know more bone density is going to be, what, good or bad, having a higher bone density? You would think it's good. You know, of course, people with osteoporosis have low bone density, and that correlates with their fracture risk. So you might say having a higher bone density maybe is protective for these people. But on the other hand, if it's this old, overly mature, kind of brittle bone, then even if you have a lot of it, it might not be a good quality bone. So it might not be protecting you from fracture risk. So I don't really have the answer for you. Nobody really knows. And part of the problem is because it's just such a rare disease, so the fracture data are very sparse. There are some registry studies that were done in Denmark where everybody's registered in the healthcare system. And it seemed that overall there was no real difference in fractures between hypopara patients and non-hypopara patients. There was some signal that patients who had it from a congenital cause of hypoparathyroidism, they might be more likely to fracture in their upper arm, whereas patients who had surgical hypopara might have a decreased fracture risk in their upper arm. But the overall fracture risk really was no different. So we don't really know. There was a recent study that showed that non-surgical hypopara patients are more likely to have vertebral fractures, but a lot of those patients were on anti-seizure medications, which can separately increase your fracture risk. So I think that we don't know, as we saw in those bone biopsy pictures, the fact that the bone structure is really abnormal, and also I didn't show you, but the bone remodeling is very abnormal on the bone biopsies, makes us think that most likely fracture risk would be increased, but I think we don't really have the data to know that for sure. In terms of the risk of complications, this study showed that patients with hypopara, this is surgical and non-surgical causes, were more likely to have seizures, were more likely to have renal complications. Interestingly, the mortality was really not significantly different. But really, it's the seizures and the renal complications that came out here. Okay, so when we're treating a patient with hypoparathyroidism, what do we want to accomplish? So it's very tricky because you want them not to have symptoms of hypocalcemia because that really makes them feel very yucky. But at the same time, like we were talking about, you can't really just give them enough calcium to feel great because then you're kind of putting their kidneys at risk. So it's a little bit like you're always walking a tightrope between getting rid of their symptoms and not getting their urinary calcium to be too high. So you want to keep their urinary calcium ideally less than 300. You want to also try to keep the phosphate level below 6. And then there's this cutoff that's always cited that you want to keep the calcium phosphate product less than 55. So this is taken from the renal literature. That's a general rule of thumb that they use, that you want to keep the calcium phosphate product less than 55. So nobody's really studied that in hypopara to see if it's a meaningful cutoff, but it's just kind of a threshold that we tend to use. So this is kind of what would guide your therapy with the patient. And of course, you don't want them to have calcium deposition in the tissues, which we think is associated with a high calcium phosphate product. So it's kind of a balancing act, because oftentimes my patients will say, I need to take extra calcium or calcitriol so that I'm not symptomatic, but I know their urinary calcium is running too high. So it's kind of really a tightrope to get it right. So the conventional treatment involves they take calcium from their diet and supplements. So which supplements would you use in a patient with hypopara? It's really the same ones we think of for our osteoporosis patients. So we could use calcium carbonate, which does tend to have a little bit more elemental calcium. It's 40% elemental calcium, and it's cheap, but you do need your stomach acid to be able to absorb it, so you have to take it with a meal. It's also fine to use calcium citrate, which you can take any time, but there's only 20% elemental calcium. You can use calcium acetate. That can act as a phosphate binder, but doesn't have as much elemental calcium. You would want to avoid a calcium phos preparation like we talked about, because they have high phosphate levels. You would want to probably treat with calcitriol, so that's 125 dihydroxyvitamin D, again, because without PTH, they don't have stimulation of the 1-alpha hydroxylase to be able to make calcitriol. So those are really the mainstays of conventional management. You do also want to give them parent D, and a lot of times people say, well, if you're giving them calcitriol, which is kind of like the end product, why do you need to give them vitamin D, especially if they're not going to be converting the parent vitamin D to the calcitriol? And I think nobody really knows, but we do know that some tissues have receptors for parent vitamin D. Some tissues have their own hydroxylase. So even if PTH isn't stimulating the 1-alpha hydroxylase in the kidney, it still would be beneficial. And we know that parent vitamin D has beneficial effects on muscle and decreased fall risk. So you are supposed to keep these patients vitamin D replete, even if you're giving them calcitriol also. You would want to give them magnesium if their mag is low, and a lot of times these patients do have low mags. And thiazides can be a helpful option because they will work at the distal convoluted tubule to increase urinary calcium reabsorption. So they'll raise the serum calcium and lower the urinary calcium. But for it to work best, the patient should be on a low sodium diet. So you need to tell your patients that. Okay, so I'm going to continue with case 3, the professor. You change the patient's regimen to calcium carbonate, 1,500 milligrams BID. That's the same dose of calcium she was on. Calcitriol, 0.25 micrograms twice a day. So we've halved her calcitriol now. 1 month later, she returns. She has started vitamin D3, 1,000 units a day, so that's a good thing. Her brain fog is the same. She heard on Facebook about getting PTH injections, but that they can cause cancer. Now her serum calcium is 8.9. Her phos is 5.4, so still above normal, but not as high as it was before. And now her calcium phosphate product is lower. It's 48. I think it was 63 before. Her 25 hydroxyvitamin D is 29, and her 24-hour urinary calcium is 345, so a little bit higher than we would like it. Your next step would be A, increase her D to 2,000 units a day. So she was on 1,000 with a vitamin D of 29. Add alpha calcidiol, 0.25 micrograms a day. Does everyone know what that is? So Gaia knows what it is. Yeah, so it's also an active metabolite of vitamin D. So we give calcitriol, 125 dihydroxyvitamin D. This is giving, it adds the OH group in the 1 position, and so your liver puts on the second OH in the 25 position. So it's available in Europe but it's essentially giving another form of activated vitamin D. It's not available here. C, begin hydrochlorothiazide 25 milligrams a day. D, consider PTH 1 to 84, 50 micrograms a day. Or E, obtain her prior medical records regarding her DCIS. So I'm hearing D. Yeah, so that's what's meant to be the right answer. So in terms of A, increasing her D, you could think of that, but a vitamin D of 29 is probably fine. And, you know, the assay's not perfect, so I think we would consider that sufficient. The alpha calcidiol would be redundant with the calcitriol and isn't available here. The hydrochlorothiazide could help. It would increase her serum calcium and lower her urinary calcium. But the PTH would probably offer her more benefits, as we'll talk about. And then in terms of her cancer, her breast cancer history and giving PTH, we'll talk about that also, but we think it's probably not a contraindication. So for the last part of the talk, I'm going to talk about Natpara treatment in chronic hypoparathyroidism. When would you think of using it? What were the data that led for it to be FDA approved? How you would dose it? And the concern about osteosarcoma risk. Okay. So the first law of endocrine disease treatment is that an absent hormone should be replaced. If you're hypothyroid, you get thyroid. If you're diabetic, you get insulin. So this was the last frontier because it was the only hormone deficiency disease where until recently you really couldn't give the replacement for it. So there was a whole body of work where PTH 1 to 34 was used to treat patients with hypoparathyroidism. So that's Forteo, but it was never FDA approved for that indication. And then we got involved with giving PTH 1 to 84. And nobody knows exactly how the two compounds are different. Nobody's done a head-to-head comparison, but they're probably very similar. PTH 1 to 84 most likely has a longer half-life. And if you give 1 to 34, it needs to be dosed probably twice a day because of the shorter half-life. And PTH 1 to 84 was approved by the FDA as an adjunct for patients with hypoparathyroidism. So if you have a patient who cannot be adequately managed on calcium and active vitamin D, that's a patient who's eligible to get treatment with PTH 1 to 84, also known as Natpara. So which of your hypoparathyroid patients would you consider it in? So these are kind of the general guidelines for who it would be appropriate for. So if they have inadequate control of their serum calcium, you would consider it. If they're on more than 2.5 grams of calcium a day or on more than 1.5 micrograms of calcitriol a day, then it would be appropriate. And the insurance company does ask you for this information. If they have hypercalciuria, renal stones, nephrocalcinosis, or a GFR that's less than 60, so some evidence of renal complications. If they have hyperphosphatemia or a calcium phosphate product greater than 55. If they have malabsorption, because then they probably would have trouble taking their calcium and calcitriol. And also if they have reduced quality of life. So that's sort of a little bit left up to the judgment of the provider, you know, what constitutes reduced quality of life. But any of these would be grounds for considering treatment with Natpara. So this is from the package insert, and it shows in healthy volunteers what happens after you take one dose of 100 micrograms of PTH injected in the thigh. You're supposed to give it in the thigh, by the way, because the absorption is slower than injecting it in the abdomen, and you want this to be as prolonged and as slow as possible. So it shows that there's an initial rise in PTH, but that the PTH falls off pretty quickly after a few hours. But then after that, the calcium starts to rise, and the calcium will start to come down by about 24 hours after the injection. But you could see that even 24 hours out, the calcium is higher than it was when you started. And the data that led to it being FDA approved was a trial that recruited hypopara patients from all over the world. It was very hard to get enough patients for it, but it was able to be done. The patients in the study were mostly Caucasian women who had post-surgical hypopara. And the study called for them first to be optimized. So before you could get PTH, they tried to get your calcium as good as possible, just with calcium and calcitriol treatment to see what additional benefit the PTH treatment would give. And the patients were randomized 2-to-1 to PTH or placebo in a blinded fashion, although we were one of the sites and you could really tell who was getting PTH because they were able to peel off so much of their supplements, as I'll tell you. So automatically, when they were randomized, everybody had to have their dose of calcitriol. The study was 6 months long. And if someone was able to completely stop calcitriol while they were on study drug, then the next thing was to start to reduce their calcium. So there was an algorithm for it. And the way you were considered a responder was kind of this triple endpoint, that if you had both a 50% reduction in how much calcium you had to take and a 50% reduction in how much calcitriol you had to take, and you were able to maintain a normal serum calcium level, you were considered a responder. So that was the primary endpoint of the study, how many people were responders in the active drug versus placebo group. And you could see in the Natpara group that 46 of the patients were responders. In the placebo, only 1 patient was a responder. And this is showing here how in the placebo group, the calcium dose pretty much stayed the same, but in the PTH group, the calcium dose was able to come down, and very similarly, in the PTH group, the calcitriol dose was able to come down. And in fact, 42% of people on PTH stopped calcitriol altogether and were on less than or equal to 500 milligrams of calcium. So very dramatic reductions in their calcium and calcitriol supplementation. At the end, they maintained a normal serum calcium, even though they were able to take much less of their supplements. Disappointingly, the urinary calcium did not decrease, which is what we would have hoped. So, we don't really know why that is. There's been some thought that if patients have been titrated to higher doses of PTH, there might have been more reabsorption at the kidney and maybe urinary calcium decreases would have been seen. Serum phosphate did come down, and the calcium phosphate product did decrease, although it wasn't that high to begin with. In terms of quality of life, it showed that people who were on Natpara did have improved quality of life using, again, this SF-36 questionnaire. But disappointingly, there was no statistical difference between the two groups. So if you just looked like within the treatment group, the Natpara treatment group improved when you compared them to baseline. But when you compared the Natpara treatment group at the end to the placebo group at the end, there was no difference between the groups. But like a sub-analysis showed that those who had worse quality of life at baseline did have the most improvement. So Gaia certainly knows more about this now than I do. But it might suggest that you could expect to see a quality of life benefit in patients who have the worst, let's say, brain fog to begin with. But patients who are kind of doing okay, you might not see such a big improvement in their quality of life. I mean, I have to tell you anecdotally that for some of my patients, it's like a real game changer. They're able to go back to work and take care of their children and really feel like they can't live without it. Right. So some thought also was that their regimen was optimized so well before they were randomized to study drugs, so that might have minimized seeing an improvement in quality of life. So to go over a little bit of the nuts and bolts of giving it. So it comes in a pen that has, have you guys given it to your patients? So it has 2 chambers in the pen. So one is a powder and one is a liquid. And when the patient begins the injection, they mix the 2 chambers together. So it stays separate until the time of initiation. And it comes in 4 different dosages, 25, 50, 75, or 100. The starting dose is suggested to be at 50. So usually that's what you'll start your patients on and have your patients have their calcitriol the same day that they're starting it. You give it in the thigh again because there's slower absorption there as opposed to giving it in the abdomen. And they'll be reducing their calcitriol concomitant with starting the Natpara. So in the package insert, they give this algorithm about what to do. So if a patient, usually when I start patients, I'll have them check a serum calcium about 3 days later, just to see, because most likely we're going to go down further. We've already have their calcitriol at the get-go, but we're going to usually go down further on their calcitriol and probably their calcium too. So if their serum calcium is above 10.6, you're going to stop their calcium and calcitriol, and you might also consider going down on the dose of Natpara. If it's greater than 9, it's recommended that you first stop calcitriol as a first step. If they're not on any calcitriol and it's still above 9, then you would go down on their calcium. If it's between 8 and 9, that's good. You don't do anything. And if it's lower than 8, you would go up on their calcium and or calcitriol. So I do have some patients who are on the highest dose of Natpara, which is 100 micrograms a day, and still need to be taking doses of calcium and calcitriol. But the vast majority are able to take much less calcium and calcitriol and frequently stop it altogether. So these are the different adverse events they could have. The paresthesias and hypocalcemia, that's really, having hypocalcemia isn't really an adverse event of the drug. In my experience, what the patients usually say the first few days after starting is they have symptoms of what would probably be considered hypercalcemia. So they'll have a headache or feel nauseous or have to urinate more at night and be more thirsty. And if you check their serum calcium, it might not even be that high, but it might be higher than it was for them, and they might be feeling the symptoms of hypercalcemia.
So I think in mice at least, there's a difference in the treatment between like a once-a-day injection versus a pump continuous.
Yes.
So we're giving this once a day, but then I heard somebody say there's going to be a pump version coming out. Is there expected to be different? That's for bone burden, so I guess for...
Yeah, that's a great question. So I'll come to that in a minute, but I think that's a really good point that ideally you would want it to be administered in a more physiologic way rather than just one bolus of PTH every 24 hours, because of course our parathyroid glands are secreting it constantly. And I'll show you a little bit about how that might have better effects. Okay, so in terms of osteosarcoma risk with parathyroid hormone, so all types of PTH seem to cause osteosarcoma in rats, but the rat skeleton is not the same as the human skeleton, and it seems to be a rat problem. What's also reassuring is that the rats who got cancer were getting much higher dosages. So the top dose in a rat that was safe to give, the non-carcinogenic dose, which is the highest dose that didn't cause cancer, was almost 5 times higher than the highest dose we would give. So it is at a much higher dose, and the rat skeleton is remodeling throughout the whole life of the rat. So this is something you must warn your patients about, and there is a black box warning on the drug, but in terms of how much is actually clinically relevant, probably we think not so much so. But because of that, it's labeled by the FDA as only to be given to patients who are not adequately controlled on calcium and D. So because of this worry of osteosarcoma, you're not going to give it to all hypopara patients, but only patients who you think, really can't be managed otherwise. And any doctor who gives it has to go through a REMS certification, which is, I don't know if anyone's familiar with it, but it's basically just like kind of a form that documents that to counsel your patient about the osteosarcoma risk. And you're never going to give it in a patient who carries other risk factors for osteosarcoma, like Paget's or open epiphyses or radiation history. Reassuringly, we know that the osteosarcoma risk is very low in the general population. And the other thing that's reassuring is that we now have very big long-term tumor registries for patients who've gotten Forteo, and there doesn't seem to be any signal of increased osteosarcoma risk. So that's with PTH 1 to 34, it's not 1 to 84, and that's with people who have normal parathyroid function and not hypoparathyroid function. So it's not exactly the same, but nevertheless, it is reassuring to know that. it's important to know that when somebody stops Natpara, they can have a rebound hypocalcemia. So if you have a patient who's on it and they run out or go on a trip and don't take it, they not only probably need to take the calcium and calcitriol they were on pre-Natpara, but might even need to take a little bit extra. And that's thought to be because the remodeling space in the bone has become expanded. So whereas beforehand there was like no remodeling going on, now with PTH treatment, there's a lot more remodeling. So it's a little bit like the patients could get a hungry bone syndrome, where more calcium is sinking into the bone and they can become hypocalcemic. Okay, so the points I wanted to make with this case are that there are impairments in quality of life, that there's slowed bone remodeling and thickened bone structural parameters, that you want to try to minimize their symptoms while keeping their biochemistries as close to normal as possible. For management, we have calcium D, and now we have PTH 1 to 84. So I'm going to just talk, we're out of time. Can you guys stay for 5 minutes or? Yeah, okay. So just our long-term data, other ways you can dose it, which were alluded to maybe with a pump, and the future. So when you give someone Forteo for 2 years, it's a 2-year thing, but these people have hypopara for the rest of their life. So it's very important. It's not going to get better. So it's important to know how long can you give Natpara for. And actually nobody really knows, but we've looked at it a little bit. And these are data that we published on the 6-year follow-up with these patients, which basically shows that their calcium in their blood is maintained in the normal range. We actually saw over 6 years that their urinary calcium did decrease. So that wasn't seen in that 6-month trial that led to FDA approval, but in our 6-year study, and now we have further data also, their urinary calcium does come down. Their FOS is maintained below the upper limit of normal. And their 125D goes up. So it's reassuring because it seems to be that it continues to work. There's no tachyphylaxis to it. And it seems to be that the effects are maintained. So we now have data looking out to 8 years showing that these effects seem to be persistent, that the calcium seems to remain within the normal range, and that the urinary calcium does seem to come down. So these are valuable data because it shows that the drug seems to work and be safe and effective with long-term administration. Their quality of life, this is showing 5 years out. All these parameters on that SF36 questionnaire seem to still be improved 5 years out. And in terms of the bone, it's very interesting what happens. This is showing 6 years out. So their lumbar spine bone density actually goes up, which we don't know if it's a good thing or not. Like usually in osteoporosis, we want the bone density to go up. But I told you that these patients already have very thick, dense bone to begin with. So we're not really clear if that's what we want to happen or not. Their femoral neck bone density stays the same. Their total hip bone density does go up. And their distal radius bone density decreases. So it's still normal. You know, this is like a 4% decrease, but because they started out so high to begin with. And again, we don't know, is that it's a good thing? Do we actually want their bone to become thinner because they're starting out with such thick bone to begin with? So I think, you know, we don't really know yet exactly what this means and, of course, what it means in terms of their fracture risk. What's interesting is that this is the same pattern that you see if you give someone Forteo. So it seems that at their trabecular bone, like at the spine, their bone density goes up, and they do, with Forteo, lose bone at the cortical bone because PTH always preferentially removes bone from cortical areas, which the wrist is primarily a cortical area. So it seems to be having this kind of, you know, location-specific effect where it's anabolic at trabecular bone and catabolic at cortical bone. And these are some of our bone biopsy data. So this is what bone biopsy looks like in a normal person. So this is the trabecular part, like the Swiss cheese honeycomb part of the bone, and the cortical bone. And if you take a hypoparathyroid patient, you could see how the trabecular bone is thicker and denser. And if you measure the cortical bone, it's also thicker. So this is a hypopara patient who was treated for, it's the same patient who was treated for 8 years. I don't know if I have the animation here. And what it basically is showing is that there's more pores that are developing in the cortical bone. So that's part of the cortical bone becoming thinner because it's kind of getting a little more excavated at. And this, I don't know if you could see the red line, that's osteoid that's being laid down. So it's a sign of the bone remodeling, that there's unmineralized osteoid that's laid down that's going to be mineralized. And then the eroded surface, these eaten away areas, is also increased. So it's a sign of the bone waking up and being stimulated. What we want to figure out is whether the bone's even being overstimulated after all these years of PTH treatment. Okay, so this is to your point about other dosing regimens. So the second law of endocrine disease treatment is that an ideal hormone replacement will mimic the tissue levels and pharmacokinetic profiles of the missing endogenous hormone. So the same way we would want to give someone with type 1 diabetes an insulin pump, so they have a basal rate and a bolus rate, that our PTH levels are kind of similar to that. You have a basal PTH level, but it actually has a circadian rhythm, and actually superimposed on that are spurts of PTH. So there are some data that show that this is if you just give one shot of PTH, so you get this initial rise in urinary calcium, and then the urinary calcium falls, which is what you want to see, but then it starts to creep up. So the point that you were raising is that what if you were to give PTH continuously? So maybe that would be more physiologic. And there was one short-term 8-week study that showed that if you gave it in a continuous pump, that the urinary calcium was lower by about 60% in somebody with hypoparathyroidism. And that might be because the nephron, when it's constantly exposed to PTH, is going to do a better job of reabsorbing calcium rather than just getting this super physiologic burst that then tapers off. So it's kind of a very tantalizing idea because it maybe suggests that with much less PTH, if it's continuous, that these patients could have a much more effective response. So it's something in the future. It's not something that's available yet, but it's certainly very appealing for the patients. And I'm not showing it, but it also seems to be healthier for their bone and not having this big anabolic effect at the trabecular bone with this catabolic effect at the cortical bone. So I think I'm not going to talk about the future since over time, but basically there are these long-acting PTH compounds that maybe would be something that could be used for patients with hypoparathyroidism. So it's rare, it's usually post-surgical, you have renal and basal ganglia calcifications and abnormal quality of life and bone. You give calcium and D, sometimes you need magnesium or use a thiazide. PTH 184 is an option, and we think now out to, some of our patients have actually been on it out to 13 years that we're following, and it seems in our cohort that it's safe and effective even that far out. So that's very promising for these patients. Of course, we need more data to understand the safety and efficacy, and I'll stop with that. So I know I went over, but if anyone wants to stay and ask me any questions, that's my pleasure.
Thank you.
You're welcome. Any questions? Yeah.
When you stop the Natpara for some reason, like patient ran out of medication or something, then you said we should put the patient back on some calcium and vitamin D. What would be the dose? Let's say the patient already have the half of the vitamin D, so you will put it back only half, or?
I would certainly go back at least to what they were on pre-PTH treatment, and they probably even need some more because there seems to be a rebound hypocalcemia when you stop Natpara. So definitely at least what they were on, and I would say probably another 50% over that.
So if the thinking is that just the first 1 to 34 acids are the active component, then why is Forteo or the short version of PTH not good for hypoparathyroidism?
It's kind of just the way the circumstances unfolded. So physiologically, you're right that we think the active form is within the first 34 amino acids, most likely. It kind of just came to be that way, that Lilly wasn't really interested in pursuing the indication for it. We actually approached them years ago when we started our study. So PTH 1-84 has the added appeal that it is actually what's made in your body. So there's some thought that the C-terminal end might have some physiologic effects also, although nobody really knows that for sure. So it's appealing to use the natural replacement anyway. 1-34 does require a BID dose. So if you're not giving it as a continuous pump, which we're not, if you're giving as an injection and you're giving it to a hypopara patient, they would need to do twice-a-day dosing with it. So, there is some thought now that with 1-84 that twice-a-day dosing might be better anyway also. Kind of a little bit of this idea of the more exposure, the better. Probably either one is good. I actually have, I think, 2 hypopara patients who are on 1-34 and not 1-84, just for different logistical reasons.
Do you have any patients vice versa, like on the 1-84 for bone?
It's not FDA approved for that. So it has been used in Europe. It was briefly available in Europe for osteoporosis. But the studies there seem to show some hypercalcemia, but that was probably more a function of them including people with primary hyperpara in their studies. So it probably would be fine to use PTH 1-84 for osteoporosis, but we just don't. We don't really have the clinical trial data to support it. There was this one study that Susan Greenspan did that did show some hypercalcemia. So it was temporarily available in Europe, but now it's not, and we wouldn't use it here, but probably it would be fine if we had a basis for it. Okay, well, thank you guys.